Good evening. On behalf of the Indian Society for Stereotactic and Functional Neurosurgery, I welcome you all to this webinar today. As you are aware, to engage and encourage the young members as well as the potential new members, ISSFN has initiated this online educational activity. Last month's webinar on stereotaxy was appreciated quite well by the participants. Today we'll present the basic aspects of epilepsy surgery. Next week on April 29th, we'll present a few recent advances in the field. We have lined up a number of webinars over the next few months on pain, movement disorder, radiosurgery, spasticity, and other functional neurosurgical subspecialties. Please check the ISSFN website for details regarding the dates as well as other information. For today's webinar, we have a distinguished panel of speakers as well as the moderator covering various aspects of epilepsy surgery. With great pleasure, now I will invite the moderator for today's webinar, Dr. Vedantam Rajshekhar, Professor of Neurosurgery, Christian Medical College, Vellore, Founder, Secretary, as well as the past President of the ISSFN, as well as the Neurological Society of India. Sir, please start the webinar. Thank you.
Thank you, Bhaskar, for inviting me to moderate this very interesting session on epilepsy surgery. I think their training program exposed to epilepsy surgery, and therefore I think this session is very important, and I hope the attendees will benefit from the deliberations over the next 2 hours. And like you mentioned, I think you couldn't have chosen a better panel of faculty for this session. So it's my pleasure to invite the first speaker, Dr. Radhakrishnan, who actually doesn't need any introduction to.
I think Professor Rajshekhar has got disconnected, I think. Probably.
Yeah, I think, yeah, he's back.
Joined back.
Yeah. Dr. Rajshekhar, you need to unmute yourself.
So was my introduction of Dr. Radhakrishnan heard, or it was not heard?
No, please repeat.
Okay. Dr. Radhakrishnan is a senior consultant in the Department of Neurosciences at Avitis Institute of Medical Sciences in Palakkad in Kerala. But he was the former director and the founder of the Madhavan Nair Center for Comprehensive Epilepsy Care at Sri Chitra Tirunal, which is really the pioneering center for epilepsy surgery in this country, and the center which has really gone a long way in popularizing epilepsy surgery and setting the standards for epilepsy surgery in our country. So Dr. Radhakrishnan is the right person to talk about on how to develop an epilepsy surgery program. Over to you, Dr. Radhakrishnan.
Thank you, Rajshekhar, for that wonderful introduction. I mean, first of all, let me thank ISSFN, especially Bhaskar, for giving me the opportunity to talk to you today evening. I've been told that mostly we are talking to the junior colleagues in neurosurgery who are hardly exposed to the epilepsy surgery. So what I will be doing is mainly to introduce you to the topic of epilepsy surgery. We'll not be going into much of the details. I hope my slide is seen and I'm also audible.
Yes, you are. Yes, slides are seen. Go ahead, Dr.
Okay. I think epilepsy surgery is one of the most underutilized kind of therapy of any form of therapy, which is not only for epilepsy, but even if you collectively take it all together. I think you're going to possibly hear the same sentence from Dr. Engel later on. And this is more true for developing countries, the low and middle income countries, where the surgical treatment gap, that means the number of patients who are waiting or eligible for surgery in the community versus the number of surgeries which are being done in the medical facilities available in that country, is unimaginably enormous. And what I'm going to talk to you is today, as Bhaskar has given me the topic, how to initiate, innovate, and sustain epilepsy surgery program in our country. And largely this is true for most of the developing countries in the world. This slide, possibly you may be seeing few times during this session. What is Telsi said among the newly diagnosed patients with epilepsy, nearly 1/3 of them in the long run will become unresponsive either from the beginning or subsequently, and that's what constitutes the drug-resistant epilepsy. That means 2/3 of the patients are responsive to the currently available anti-seizure medications, but 1/3 would remain uncontrolled. See, the options available for the treatment of this, what you call the drug-resistant epilepsy, as it is called now, terminology which is recommended by the International League Against Epilepsy. The surgery is considered primarily because that's the only treatment which can cure epilepsy, in the sense that not only make the patient seizure-free, but in the long run, a proportion of them can also become free of anti-seizure medications. And the selection of the outcome of epilepsy surgery largely depends upon the way in which these patients are selected, what you call the ideal surgical candidates. And that's usually done through what you call the pre-surgical evaluation. You're going to hear a full talk for 15 minutes on this subject by Dr. Chhatrapati Rathod. Here I just want to mention that it involves a multi-speciality organization. And this I'm telling because it is relevant to the epilepsy surgery programs which we are going to develop. Suffice to say that the drug-resistant epilepsy is a kind of complex group of patients. Some of them can be selected straightforward by simple non-invasive evaluation like the MRI and the video EEG monitoring. And Dr. Engel is going to talk about the surgically remediable syndrome because the MRI demonstrable lesions like mesial temporal lobe epilepsy with hippocampal sclerosis or low-grade neoplasms or large hemispheric lesions like HHE syndrome and the Rasmussen. These are clear-cut cases which can be selected by non-invasive means. If this information is discordant, then you will have to go in for the additional non-invasive test. And those majority of the MRI negative patients, they constitute a significant proportion, nearly 30 to 50% of the patients, depending upon the type of referrals bias involved in the complexity of these patients. They would require what we call the invasive monitoring to select these patients. It's important to keep this in mind because the kind of epilepsy surgery programs initially which evolves would like to cater to the step one, or what we call the clearly selectable patients by non-invasive means, and refer the patients who require advanced investigation or invasive evaluation to the centers which are well equipped and established with a lot of expertise in this field. Now, when we talk about epilepsy surgery in India, or for that matter in developing countries, we'll have to start the program either at the local or at the national level by keeping in mind what you call the 4 A's, the availability, acceptability, accessibility, and affordability. This is true for the healthcare strategies for any kind of disorders and not different in for epilepsy surgery. Now, with respect to our country, there is an enormous amount of population. Nearly 1 in 5 of the patients with epilepsy live in our country. And much more important to remember is that nearly two-thirds of our population are still rural. So most of the centers or the neurologists, they practice in urban or in the cities. So this is the people who are where the bulk of the patients with epilepsy live. They are left out because they may not be able to reach the centers which are doing the pre-surgical evaluation and surgery. So this is something which I'm going to emphasize during the later part of the lecture, how to overcome this, what you call the dichotomy, or the kind of where the needy people are there, but the facilities are not available and they are unable to travel to cities to get this evaluation done. And in spite of the enormous the progress which we have made, I think we should remember that we are the 7th largest economy in the world. But because of the enormous number of the bulk of the population, still we belong to the low and the middle income countries. So at whatever kind of programs, the epilepsy surgery programs which you have to evolve, they should be catered to the needs of majority of the people, and also it should be affordable to them in a kind of low cost kind of these things, so that it can be made available to majority of the people. Now here I should emphasize that the nearly 2/3 of the patients with epilepsy are primarily treated by the primary and secondary care physicians and the pediatricians or psychiatrists. Only 1/3 of them, or less number, will be referred to the neurologist, and maybe less than 10% will ultimately reach the epilepsy specialty centers where most of us are working. And most of the neurosurgeons also will be interested in epilepsy, will be located in these areas. So unless we can ultimately, to have these patients undergo pre-surgical evaluation, they have to get referred. They have to be, the diagnosis of the drug-resistant epilepsy will have to be made early, and these patients have to be referred. So unless we educate the primary and secondary care physicians, pediatricians, and the psychiatrists regarding how to diagnose drug-resistant epilepsy early, when to refer them to a neurologist, and the neurologist also should know whether these are potential surgical candidates, and they refer to a comprehensive epilepsy program, the overall, the kind of at a regional or national level, we may not be able to make an impact as far as the surgical treatment gap is concerned. Now, the reasons for this delays, as I mentioned, is those who are seeing these patients primarily don't know when to diagnose drug-resistant epilepsy. They may not even be knowing that when we did a survey in Kerala with the primary and secondary care patients, less than 20% knew that there is something like surgical treatment available for epilepsy. There's also a lot of misconceptions, even among the physicians and the neurologists, that epilepsy surgery can lead on to problems with the memory and the significant problem with the behavior, the motor deficit, etc. That also, it's not only the problem in our country, even in US and in developed countries, this happens. So this is again something we have to overcome by educating the primary, secondary care physicians, the neurologists, and also the public. Now, just to briefly say that when the patient do not respond to carefully chosen anti-epileptic medication in appropriate dosages, either used alone or together, you can make a diagnosis of drug-resistant epilepsy. The chance of seizure freedom in such patients with continued medical treatment is something like less than 10 or 20%. And when you refer these patients, if you tell them that I am referring you for epilepsy surgery, majority of them are scared and may not go. And this is something which I heard in one of the talks which Dr. Engel gave a few years ago. He says that don't tell them that I am referring you for surgery. But you say that as your seizures are not controlled, you require an expert evaluation, find out the reason for the lack of responsiveness to the anti-seizure medication. And if you tell like that, and it's up to the epilepsy surgery center or the comprehensive epilepsy program to decide whether you require surgery or alternate modes of treatment for drug-resistant epilepsy. That might take away to some extent the fear about the epilepsy surgery. And Chaturvedi did a few years ago an exhaustive survey of the epilepsy surgery programs in our country. Very few countries have got such a data available. This they looked into up to the 31st of July 2016, the epilepsy surgery, the prevalence and the pattern of the epilepsy surgery in our country. What it came out is that there are 39 centers which are doing epilepsy surgery till that time. And as you can see that nearly all of them are located at or close to the large metropolitan cities. And you will also notice that the central part of India, where the bulk of the population stays, there are hardly very few centers. So there is a kind of the skewed distribution again with the epilepsy surgery centers. This again I'm going to touch upon later in as a few of my last slides. And altogether he came out with the data that nearly 750 epilepsy surgeries are being done per year. Now let us look at it, what impact it can make with the large, enormous number of patients who are waiting there. Considering the prevalence of epilepsy is 5 per 1,000, and nearly 25% of them would be drug resistant. Nearly there will be, and out of which nearly half of them are potential surgical candidates. There are something like 500,000 candidates, potential candidates for epilepsy surgery in our country anytime. And with the present kind of the surgeries being done, only 2 out of 1,000, that means 0.2% of the eligible patients nowadays undergo pre-surgical evaluation or epilepsy surgery. So you can imagine the enormous amount of treatment gap which is existing there, and anything which could be done to minimize the treatment gap is going to be most gratifying as far as the treatment of epilepsy is concerned. Now here it's impossible to develop, let's say, thousands of epilepsy surgery centers in the country. So we'll have to ultimately come up with some kind of strategy. Here I'm going to show you 3 examples. One is from Africa, from Uganda, one of the poorest countries in Africa. Although this data is a bit outdated, more than a decade ago, it is still worth going through it. And when this the report was made, Uganda did not have an MRI scan. They had only a nearly high resolution CT scan. But somebody who got trained at the Montreal Neurological Institute established a video EEG program, and he was also interested in neuropsychology. And then what they did was they sent their data, which is collected, both the clinical and the video EEG information, to Montreal Neurological Institute. And you can see the name of the late Frederick Anderman within that thing. And it is got reviewed by him or by his team to decide about the ideal candidate for epilepsy surgery. And Dr. Bowling, the neurosurgeon from the West Virginia University, USA, he went to Uganda a few times and trained the neurosurgeon there to do the epilepsy surgery. So this is a clear example of a partnership between resource-poor and resource-rich countries, both in the technology, expertise, and the human resource development. So now we are more used to this kind of virtual meetings as well as the telemedicine, etc. And in fact, I think we should thank COVID and pandemic for educating us and how to virtually have these kind of consultations and the decision regarding surgery and all these kind of things, so that most of the youngsters would be able to understand it better than what we understood during our times when we were developing the epilepsy surgery. Now let me just go through two examples from our country, which is almost done in the same way. These are all the out of the authors, most of them are the fellows who did the epilepsy fellowship in Sri Chitra, and Anis, Neeraj, and Chaturbhuj. They, for example, Anis went to Udaipur in Rajasthan. Neeraj went to the Maharashtra and Chaturbhuj went to Baroda, and Neeraj actually went to Nagpur. So what they came together and then exchanged the information, used their expertise, and took the help of Dr. Girish Menon from the Kasturba Medical College, as well as Aditya Gupta from Delhi, to come and do the epilepsy surgery along with the locally available neurosurgeons. So through this process, as you can see, that the center of India, which I previously showed, that there is a large area which is uncovered by the availability of the epilepsy surgery. These centers got located there. And for example, Nagpur, the epilepsy surgery was started in June 2012, and then in the Baroda, and lastly in Udaipur. And altogether, they have done the 125 epilepsy surgeries. As you can see, majority of them, 2/3 of them are, as expected, the temporal lobe epilepsy surgeries. And as you can see that out of the number of patients who have completed a minimum of 1 year follow-up, nearly over 90% of them are belonging to younger class 1 outcome. And except for one patient who developed a hemiparesis which lasted for more than 3 months, majority of the complications were very transient and recovered within the next 2 or 3 weeks. And again, note that the average cost was less than 1 lakh, and that would come up to less than $1,500 US. And I think Dr. Engel, if he's among the viewers, he is going to comment on this later on, hopefully. And this again a clear example of how we could pool not only the resources, expertise, and the facilities to come up with epilepsy surgery programs in a very effective and within a very effective way. Lastly, I'm going to show you 3 or 4 slides in which what we have seen in the previous slides was in what we call the Tier 2 and the Tier 3 kind of cities. Now we are going to move away from cities and into a semi-urban area. When I took over this the assignment at the Avitis Institute of Medical Sciences, it was exactly to do the same thing. Can we have an epilepsy surgery program in a semi-urban setup? As you can see that this institute is located in a kind of semi-urban area. The nearest the city is Palakkad, which is nearly 50 kilometers away. And the 2 airports, Cochin and Coimbatore, almost equidistant, is almost 150 kilometers away from the hospital. The hospital is quite modern and is located on the backdrop of Nelliyambadi Hills, and it's a kind of serene and wonderful. The ambience and excellent facilities are available. And we have got a fairly advanced epilepsy monitoring unit, which can cater to the needs of 2 patients for day and night monitoring. And we have got a 1.5 Tesla MRI, but there's no issues there. For example, to get a 3T MRI or FMRI or diffusion tensor tractography, I usually take the help of Dr. Keshwadas at the Sri Chitra. And then for the PET scan, we send regularly to the Amrita Institute of Medical Sciences, and to make the NIMHANS Bangalore. And Dr. Girish Menon, as you can see that some of you would immediately recognize him, he comes once in a month or once in 2 months, and we undertake epilepsy surgery for 2-3 days together. And some of you may recognize our Chitra alumni, Anudat Ramandani is our local neurosurgeon. They together undertake the epilepsy surgery. We have so far we have undertaken our program started in September 2019, and the last surgery was done very recently on March 27th, 21. Altogether, we have done 22 epilepsy surgeries, and as you can see that we have even shifted to selective medical hypercambectomy for mesial temporal lobe sclerosis, and both straightforward as well as the difficult epilepsy surgeries have been undertaken. And only 2 patients of extratemporal had mild hemiparesis, which resolved. Out of 7 patients who have completed 1 year, 6 of them are seizure and aura free. Again, suggesting that it is a careful selection and kind of coordination of the program. As you saw that it involves all the people, the anesthesiologist, the operation theater people, as well as the EEG technologist and the VIBA, the coordinator of the program. So it's a kind of team approach which is required for epilepsy surgery. And now, a few years ago, Dr. Engel invited me to give a talk in Vienna. What should be the minimum requirement of epilepsy surgery program, or if you want to develop an epilepsy surgery program in a developing country? I think the most important, again, I want to re-emphasize, is a motivated team and a team leader. That's perhaps the most important thing is required. And you have to have a dedicated clinic for the drug-resistant epilepsy patients, where they can be screened and can be selected for the video EEG monitoring. And you would like to have, depending upon the workload, 2 or 3 monitoring units. Initially, you may start with them and subsequently you may expand. You possibly, most of patients, by the time they reach, they would have already had their MRI. So you may not, if you need a 3T MRI, there may be many centers not far away who will be required, and even with 1.5 MRI, you can select most of the surgically remediable lesional syndrome. So that is a minimum. I think the most important is, even if you've got a team leader and a motivated team and a video EEG monitoring program and an epilepsy clinic which is regularly running, that's enough for you to start. You, along with the neurosurgeon, along with the neurologist and the neuroradiologist, and others can be either part-time or the full-time. So the last 2 slides will tell you how to develop a regional epilepsy center. As I already mentioned, I don't want to repeat it, and then slowly you can add it up. Only want to emphasize that when we did that in Sri Chitra in 1994 to almost up to 2000, we did only the straightforward cases, because ultimately how your program is going to survive will largely depend upon the initial patients who are going to be your ambassadors. There, if you fail, many patients may not like to come to that center. So that's why initially select simple cases, and with expertise, you can slowly and steadily improve. That means you have to be a learning organization in order to survive in the epilepsy surgery program. And at a national level, if you look at, and that's what we call a national epilepsy surgery program, I mean, it again can be taken through 3 steps, and we will have to educate the primary and secondary care physicians, pediatricians, and other people how to identify the drug-resistant epilepsy early and refer to that. Then there can be epilepsy care centers, which including surgeries, which can be done by non-invasive means. With the population, depending upon the population in each state, there may have to be 3 to 5 centers of this type in the state. And then there can be 10 to 15 national epilepsy surgery centers where every facility, including advanced kind of neuroimaging, stereo EEG, etc., are available. And they are the people who should help in developing the human resource development and pass on the kind of manpower as well as education to the others, to the regional centers and to the community, so that finally the patients will reach the correct centers and undergo the correct investigation, and they will be appropriately selected with very good outcome. That's an advanced surgery program. So we have formed the Bhaskar was involved in developing this, what we call the National Epilepsy Surgery Support Activity Network. We call it NESSAN. The objective is to help the junior colleagues in developing the epilepsy surgery program. And we conduct the virtual, the what you call the patient management conferences, in which cases are discussed, and then the usually in the evening for 2 hours. And I mean, these are conducted twice a month, depending upon the number of cases, in which every kind of the points in favor and against are discussed, and finally even decided what kind of surgical strategies to be done. And there is also multi-center collaboration in communication and the research. And we have also annual meeting, both physical and virtual. Some of you would have attended the virtual meeting recently, in which Gonzalez Martinez, the person who is one of the authority on stereo EEG, as well as Dean Gothman, again, a very good epilepsy electrophysiologist, and also Dr. Emilio Peruca, they participated in this meeting. And there's no membership fees. We don't have a secretary, president, or a treasurer. This is only each one of us are a part of NESAN, and you can contact us through anytime through the NESAN India for any kind of difficulty. We are there to help you. Thank you very much for your attention.
Thank you, Dr. Radhakrishnan, for a very illuminating talk on how to set up an epilepsy surgery program. With your vast experience in setting this up in various centers and with different levels of sophistication, I think you have provided a roadmap for the participants to follow, depending on their situation, so that epilepsy surgery can be set up in centers with different types of facilities and different levels of facilities. We'll take the questions at the end, and so we'll move on to the second talk now. And for that, I invite Dr. Rathod, who is a professor of neurology at the SBKS Medical Institute and Research Center in Vadodara, in Gujarat. And as you would have gathered from the talk of Dr. Radhakrishnan, he trained at the Sri Chitra Tirunal Institute and was closely associated with Dr. Radhakrishnan, and continues to be associated with him in various capacities. So he will be speaking on the pre-surgical evaluation in adults. Over to you, Dr. Rathod.
Thank you, sir. Thank you very much for the kind introduction. And I thank ISSFN as well as Professor Malla Bhaskar Rao for the kind invitation and to share my experience of pre-surgical evaluation with you. Sir, my slides are visible and I'm audible?
Yes, there. Yeah, yes.
Sure. So as usual, Professor Radhakrishnan has made my job very simple. And from the how to set up the program, we will go directly to the process of the pre-surgical evaluation. I will be talking on mainly the pre-surgical evaluation in general, which will apply to the both the adults and pediatrics. Probably Professor Udani will speak on the specific aspects on the pediatric epilepsy. So as is been told, and it has been proven through the multiple studies, long-term follow-up studies from all over the world, that approximately 1/3 of the patient with newly diagnosed epilepsy do not respond to the optical medical therapy. So these are the patients who are known as the drug patients or people with drug-resistant epilepsy. So approximately 1/3 people or 1/3 patients with epilepsy are resistant to the optimal anti-epileptic drug treatment. And it has also been shown that if the patient has failed 2 drugs, if the patient has not responded to adequate trial of 2 drugs, then chances of a subsequent drug trial working is less than 5%. So based upon these principles, the definition of the drug-resistant epilepsy, which has been given by and endorsed by the International League Against Epilepsy, this is the failure of adequate trials of 2 tolerated, appropriately chosen and used anti-epileptic drug schedules. So whether in monotherapy or duotherapy, if the patient has failed 2 drugs, then it becomes a candidate for the or to call as drug-resistant epilepsy. this concept is pivotal to the understanding of the pre-surgical evaluation, because whatever the understanding as of now, which stands today, we offer pre-surgical evaluation or epilepsy surgery for the purpose of the cure of epilepsy to only those patients who have a drug-resistant epilepsy. So as of now, the patients who are not drug-resistant and who may be having a clear-cut, especially for the surgeons who may be having a clear-cut MRI lesion, but if they are not drug-resistant, as of now, at present status, for the epilepsy perspective, it is not advisable to offer epilepsy surgery. And it has also been shown through at least 3 of the randomized controlled trials and subsequent multiple long-term follow-up study that these patients with drug-resistant epilepsy have a best chance of good outcome or have a best chance of the seizure freedom with epilepsy surgery. So this was the landmark trial from the Canada, where this was a randomized controlled trial where 80 patients were underwent randomization, 40 patients underwent surgery, and 40 patients with continued medical treatment. And at the end of 1 year, around 60% of the patients were seizure-free. So there was a significant difference in the patients who underwent surgery. So these were the randomized trial. There has been 2 more randomized control trials. Apart from this, the multiple long-term follow-up studies have shown that in carefully selected patients, and especially in the temporal lobe epilepsy patient, approximately 80% of the patient can become seizure-free and 50% of the patient can become drug-free. So this was our study of 310 patients from Sri Chitra. And similarly, in the extratemporal lobe epilepsy, approximately 60% of the patient can become seizure-free. So obviously, what we are talking is the patient, 30% patient develop drug-resistant epilepsy, and best chance of outcome in those group of patients is by offering epilepsy surgery. So these are the prerequisites for epilepsy surgery. We are talking of epilepsy surgery and not the lesional surgery. Patient should have medically refractory seizures. Patient should have a seizure-related medical and social disability. All the patient might be having refractory seizure, but seizures are non-disabling. Patient having few clonic jerks once in a while, and which is not disabling, then probably we may not offer epilepsy surgery. So there should be a disability have to be established. Thirdly, patient should have a fairly localizable epileptogenic zone. We should be sure that the seizures are coming from which area of the brain, and we should be able to make patient seizure free, or there is a reasonable chance of good outcome following the surgery of that area. Also, acceptable risk-benefit ratio for the surgery. This is especially applicable to the locant area lesions, and there should be a fair chance of improvement in quality of life. So these are the prerequisites of the epilepsy surgery. Basically, if patient has a disabling drug-resistant epilepsy, usually those are the patients who are candidate for epilepsy surgery. And these are the basic requirements. And there are only 2 steps in any pre-surgical evaluation. First is the accurate localization of the epileptogenic zone. And I'm not going to the details of what is the epileptogenic zone and these for the beginners, but the basic idea is that we should be able to establish that seizures are coming from that particular local area in the brain. And to localization is a multimodality approach. There are multiple investigations that require, and none of the modality is absolute. Okay, MRI provides absolute idea, or the video EEG provides absolute idea. It is not like that. None of the modality has absolute value. All have limitations, and that is why we require multiple modality to give a concordance that so that establishment of the concordance between the different modality is essential for a successful localization of the epileptogenic zone. And following, this is the domain of the epileptologist, and subsequently once you localize, this is the domain of the surgeons, to assure complete and safe resection of the epileptogenic zone. Although I understand that boundaries are blurring, and surgeons are still, now more and more surgeons are also getting interested in localization area also. So in case of the localization, there are certain clear-cut epilepsy syndromes which we know the natural history, and which we know that their prognosis after the failure of 2 drugs is very, very dismal, or they are not going to, there is usually a protected and a progressive course. So these are the people, or these are the syndromes which are known as the surgically remediable syndromes. Dr. Engel is going to speak on that. Classically is mesial temporal sclerosis, low-grade lesions like tumors, focal cortical dysplasia, in India scars, as similarly the hemispheric lesions like gliosis or Rasmussen encephalitis. So these are the non-surgical amiable syndrome where the process of the pre-surgical evaluation is a bit easy. But we have other group of patients who have a drug-resistant epilepsy, patient with multifocal lesions like tuberous sclerosis, patient with normal MRI, patient with dual pathology, MTS and the neurocystic sarcosis, patient with bilateral lesions, and patient with bilateral heterotropia. So these are the difficult group of patients where we have to exhaust the different modality to reach the definite level of confidence about the localization of the epileptogenic zone. So pre-surgical evaluation, and this slide you must have seen from the Professor Radhakrishnan and earlier also. So this basically our idea is there are different modalities we use starting from the clinical history, MRI, video EEG, neuropsychological evaluation. These are from the step 1 of the pre-surgical evaluation. And then additionally we require in certain group of patients, we'll come to that in later on the second slide, functional imaging as well as in a rare group of patients, we require invasive intracranial monitoring to localize the epileptogenic zone. And success of the epilepsy surgery depends upon the accuracy of the localization, which is the part of the epileptologist, and completeness of the dissection, which usually involves both epileptologist as well as a neurosurgeon. So it is a stepwise approach, and you require the different modality, but the basic modality, as Professor Radhakrishnan has already told, basic modality remains the clinical history, MRI and video EEG. These three modality as of now is must in any kind of epilepsy surgery evaluation. So there are certain group of patients, especially the surgically remediable group of patients, can be selected with these modalities alone. So these are the group which have a non-eloquent lesion like focal cortical dysplasia or the tumor which is away from the eloquent area, hemispheric lesion or clear-cut unilateral MTS. So these are the patients who can be selected with the minimal stage 1 of the evaluation. Then there is another patient where you cannot localize based upon this lesion, based upon this information. Then there is a stage 1 or stage 2 of the evaluation, which basically includes multiple investigation, including SPECT, PET, MEG, EEG, fMRI, and functional MRI. Basically the two large investigation to reduce the chances of the deficit. And these are the patients who have a temporal lobe epilepsy with normal MRI or patient who have a bilateral MTS. Usually these are the patients which will require stage 2 approach. And then patient who have a normal MRI, especially extratemporal lobe epilepsy, patient have a eloquent area lesions or patient with multifocal lesion which require a stage 3 evaluation, which basically involves the intracranial monitoring. So you can see that there is a different stages. Each patient doesn't require all the investigation, and the number of investigation directly correspond to the complexity of the case. So as the number of these stages increases, the complexity of the cases increases, but the number of patients usually decrease. So majority of time, 80 to 90% of this may be 80% to 90% of the patient usually can be evaluated with the stage 1 or stage 2 evaluation, and approximately 10 to 20% of the patient will require stage 3 evaluation. So this is how usually we go against the approach of the pre-surgical evaluation. Especially for the surgeon, to give you an example, this is to cut a short story long. This is a 28-year-old male who had a history of febrile seizure and then subsequently unprovoked seizure from 16 years of age. Semiology was characterized by the behavioral arrest, stare and unresponsiveness, and occasionally generalized tonic-clonic seizures. And he was on 4 drugs and he was drug resistant. CT scan as well as the MRI showed there is a calcified lesion, and which was thought that it may be responsible for the drug resistant epilepsy. EEG at some points shows right frontal spike, which was corresponding to the area of the calcified lesion, and then there were some generalized spikes which is possible in a case of frontal lobe epilepsy. And this was the patient's seizures recorded. So if you observe clearly his hands, you can see now, okay, there is some jerking which is happening in the hand. And yes, there is some jerking which starts in the, and then you can see still there is some jerk which is causing the move, and then suddenly it falls down and there is a generalized tonic-clonic seizures. So this was the initially myoclonic jerks and the generalized tonic-clonic seizure. This patient has actually juvenile myoclonic epilepsy, primary generalized epilepsy, and the calcified lesion was actually innocent bystander. It was not responsible for the epilepsy. So the first principle or first pearl for the, especially for the neurosurgeons, presence of the MRI lesion alone is not sufficient for epilepsy surgery. With the recognition of this epilepsy surgery, there are many people who think that, okay, if there is an MRI lesion, we can resect it out. So we have to establish the cause-effective relationship, especially in cases of MTS and especially this kind of calcified lesion. In any case, video EEG and the cause-effect relationship has to be established before proceeding for the epilepsy surgery. This is another case to give you an example. This is a 35-year-old male who has an unprovoked seizure from 25 years of age. Semiology was suggestive of like a temporal lobe epilepsy, and he was also drug resistant. This was an interictal EEG. We showed clearly there was a left temporal, anterior temporal spike. And this was the seizure which was recorded. So he has become behavior arrested, and there is not much of response. Probably smiles and not a Ross response. It's a classical of a temporal lobe seizure. And interictally, so this is the ictal EEG. We showed that clearly a ictal onset from the left temporal lobe epilepsy. So the patient history is suggestive of temporal lobe epilepsy. EEG and video EEG is clearly suggestive of both the semiology and suggestive of temporal lobe epilepsy. But what we're missing is the MRI. So MRI, hippocampal, both hippocampi as well as the temporal lobes are completely normal. But what we see is there's a focal cortical dysplasia in the basifrontal area. So this is to highlight that all this investigation, especially semiology and EEG, have important limitations. So MRI has limitation as seen in the previous case. Semiology and EEG, because semiology is predominantly depends upon the propagation of the seizure and the area which comes during that propagation. So it mainly largely determined by the propagation of the seizure and not by the seizure onset. So this limitation we have to understand. Similarly, the interictal EEG, which is usually the widespread than the actual ictal onset zone, and the ictal EEG, which again is determined by the propagation. So we have to again to highlight these two cases that all these modalities have certain limitation, and that is why require concordance between the different modalities to achieve a successful epilepsy surgery localization. So to again, MRI and video EEG are the two most important modalities. If your MRI is good, like MTS, EEG also classically localization, this can be selected directly with that and usually have a good seizure outcome. 80 to 100% patient become seizure free. If one of them is not good, like MRI is good, but EEG is not very localizing or EEG is more diffuse, still this patient can be selected with non-invasive evaluation, but their chances of seizure outcome will be approximately 60%. On the other hand, we have another group of patients where EEG is very good, but MRI is not good, either normal MRI or bilateral MTS. Still, these patients, usually majority of these patients will require intracranial monitoring, and then chances of seizure freedom is usually 1/3 to 1.5. And this patient who have a MRI is not good as well as EEG is non-localizing, this patient can be directly excluded from the surgery. These patients are usually not surgical candidate, and based upon this initial evaluation, we can exclude this patient from the surgery. So pre-surgical evaluation not only establishes that epilepsy surgery requires in which case, it also establishes that which we have to avoid the epilepsy surgery. In certain cases, apart from that, we require additional investigation. I have given the list of PET, SPECT, and the MEG. So if patient has a non-localizing, non-invasive data, especially patient has a normal MRI, or there is a clinical, electrical, and radiological discordance if it is not establishing localization. If the lesions and epileptogenic zone is co-localized, or if patient has a dual and multiple lesions, usually additional tests are required, and majority of these patients will end up with intracranial monitoring. And in this, the most important investigation in patient with normal MRI as of now in today's world is PET scan. So if MRI is normal in around 50% of the patient, in those patient with, approximately 50% of the patient PET can provide some area of localization to at least to guide where the epileptogenic zone is there, or where we can put the intracranial electrode. Intracranial EEG is the final gold standard in difficult cases, but we have to understand its limitation. It is as good as our hypothesis based upon the non-invasive evaluation. So if your non-invasive evaluation is not good, or there is no certain hypothesis, we cannot go for the intracranial EEG. We can sample on the limited area, and we cannot do the phishing expedition. So that it has to be reserved in the most difficult cases, and it has to be properly evaluated before proceeding for the intracranial EEG and stereo EEG. So to summarize, the clinical history, video EEG, MRI, and neuropsychological are the basic evaluation tools. And if there is a concordant localization, you directly go for surgery. If there is a localization is achieved but eloquent lesion, then surgeons come, we can do fMRI, VADA test, and awake resection, and sometimes with the grid and cortical stimulation and mapping. So these patients usually have a very good outcome. If patient has a good video EEG, but the MRI is not good, normal MRI, or good MRI but discordant video EEG, usually this patient can be evaluated or can be undertaken with the stage 2 evaluation, and they can be offered either direct surgery or the invasive evaluation. On the other hand, this is the red color. If there is a non-localized, diffuse, or multifocal onset based upon the video EEG and MRI, you can directly tell that these patients are not surgical candidates. So what I've tried to highlight you that it is a multi-modality process. It is a complex process, and each modality has a limitation. Each patient doesn't require every investigation, and it has to be judicially selected. Similarly, in our country, because of the resource limitation, if investigation is available, it is not that it should be done in every patient. All the investigation has to be judiciously selected based upon your initial hypothesis, which is generated by the MRI and video EEG, which are the two basic tests. And each hypothesis has to be a correct hypothesis at each step. And subsequently, now we can talk about improvements in the structural imaging, functional imaging, PET, and stereo EEG are now improving the outcome, and we are able to select more and more difficult cases. If all this process we have summarized in this article, which was published in seminars in epilepsy in epileptic disorders, so you can please go through it. And thank you for your kind attention.
Dr. Rajshekhar?
I think sir got disconnected probably, yes, looks like.
Okay. So I'll moderate on his behalf while he's away. Dr. Rajshekhar has just joined. Dr. Rajshekhar, do you want to? Okay. The next talk is also on pre-surgical evaluation, and that is going to be given by Dr. Rajesh Udani.
Yeah, I think he has joined. Dr. Rajshekhar has joined.
Yeah, I can see him.
Yeah, sorry, I lost the connection. Yeah, so to talk about pre-surgical evaluation in children, it's going to be Dr. Udani, who is a pediatric neurologist and an epileptologist from the PD Hinduja Hospital in Mumbai. Over to you, Dr. Udani.
Can I interrupt? This is Dr. Engel. I just joined. I thought I was supposed to speak at 8 o'clock. I gather you're not according to schedule, but I have a limited amount of time. So I can't wait another half an hour.
Yeah. So soon after this talk, Professor Engel will be.
Otherwise, he can finish his talk, no problem. I have no issue.
Why don't we do that, Bhaskar? Is it okay?
Yeah,
Dr. Udani, is it all right with you?
I have no problem.
Yeah, sure.
Oh, great. Okay.
Yeah.
So,
I'll
Dr.
just stop
Engel, you will
sharing.
be on as soon as I introduce you. Yeah. So here it goes. So the next speaker is going to be Dr. Jerome Engel, who actually doesn't require much an introduction, but just for formality's sake, he's the Jonathan.
I think he again got disconnected, I think.
Bhaskar, do you want to moderate till then? You need to unmute yourself, Bhaskar.
No, I'm sure Dr. Rajshekhar will be able to join us. Yeah, he is with us.
Connection is unstable with.
Yeah. Yeah, I think he's with us.
Speaking on surgically remediable epilepsy syndromes.
Dr. Ashekar, we lost the connection. Can you start again, please?
Okay. My introduction was not heard?
Yeah. Yes. Please start again.
Okay. So it's a pleasure for me to introduce Dr. Jerome Engel, who's the Jonathan Sine Distinguished Professor of Neurology, Neurobiology, Psychiatry, and Behavioral Sciences, and the Director of the UCLA Seizure Disorder Center at Los Angeles, USA. He is, of course, a legend in the field of epilepsy and epilepsy surgery, known for the Engel's classification of outcome following seizure surgery. And he'll be speaking to us today on surgically remediable
Professor Engel, if I could suggest that you could start.
Yeah, I need to share my screen.
Yeah.
Okay, can you see and hear me?
Yes, it's clear. Yeah.
All right. Well, thank you very much for inviting me to this. I'm sorry to impose, but I just had a limited window of time, so I appreciate your accommodating. Bhaskar asked me to talk about surgically remediable epilepsy syndromes. When I began, we had only two drugs, Dilantin and phenobarbital, so it was very easy to determine that patients were drug resistant. We only had two drugs to try, but there's so many drugs now, it would really take a lifetime to try every drug in every single patient. So we need a better way to determine who is a drug resistant and therefore who are surgically remediable. The classic study was the study by Kwan and Brody that found that if the first anti-seizure drug failed, only 11% eventually became seizure-free, and if two failed, only 3% eventually became seizure-free. So that my slides aren't advancing.
Can you please
there we go. Okay.
Yeah.
I got it.
Yeah.
So not that long ago, the International League Against Epilepsy came up with a specific definition of drug-resistant epilepsy. I'm sure you're all familiar with it, that all a patient needs to do is to fail two drugs, either alone or in combination. And the chances that a third drug will work are so small that they ought to be considered as potential surgical candidates. But even before that, we were very concerned that if first choice drugs fail, patients should be referred to an epilepsy center where surgery is offered, because they might have surgically remediable syndrome and be surgical candidates. So what is a surgically remediable syndrome? Well, we came up with this idea before the definition of drug-resistant epilepsy, because these are the patients who, if they fail a couple of drugs, are most likely to become seizure-free with surgery. They have a known pathophysiological substrate. They have a predictable natural history. That is, that after failure of one or two drugs, no drugs subsequently will work. So they're unresponsive to pharmacotherapy. And there are progressive features like developmental delay for infants and small children, or interictal behavioral disturbances in older patients. They're the most effective surgical candidates because pre-surgical evaluation can be performed non-invasively. And by definition, there's a 70 to 90% chance of complete elimination of disabling seizures. The disabling behavioral consequences can be avoided or reversed, but only if surgical intervention is early. So early recognition and early referral to an epilepsy surgery center is essential for these surgically remediable syndromes. These are the surgical remediable epilepsy syndromes. Mesial temporal lobe epilepsy is the prototype. I'm sure you're very familiar with it, and I'm going to spend most of my time talking about these patients because these are far and away the most commonly treated surgically worldwide. And I suspect in India, you have thousands of patients who, with this condition, who are surgical candidates who have never been referred to an epilepsy center. But also focal epilepsies due to discrete resectable structural lesions, catastrophic secondary epilepsies due to diffuse hemispheric disturbances that are candidates for hemispherotomy. And then finally, more recently, hypothalamic hamartoma with gelastic seizures is considered a surgically remediable syndrome. So you don't need fancy tests to demonstrate that patients have hemimegaencephaly or other hemispheric conditions to determine which hemisphere is responsible for the seizures in these patients with usually infants and young children. But on the right is Rasmussen syndrome. So in these other conditions, patients have hemiparesis with a useless hand, and hemispherectomy or hemispherotomy doesn't produce additional neurological deficit. Problems exist concerning Rasmussen syndrome, where often the intractable seizures begin before there's a useless hand, and it's necessary to be certain of the diagnosis and the progression, which will eventually result in a useless hand in order to justify doing a procedure that's going to cause hemiparesis. It's important to do this early in patients where the deterioration is in the language dominant hemisphere in time for language to switch to the other side. Now, I wanted to talk particularly about the syndrome of mesial temporal lobe epilepsy. I assume most of you are familiar with this, but it's a very well-defined syndrome where there's an increased incidence of complicated febrile seizures or other predisposing insults within the first few years of life, and an increased incidence of a family history of epilepsy, suggesting that there is a genetic predisposition to develop the syndrome given an insult within a particular time window. The onset of seizures classically is in mid to late childhood, although lately we seem to be seeing a lot of patients where the onset of habitual seizures are later in life, even in adulthood, but the syndrome otherwise seems to be exactly the same hippocampal sclerosis, and the response to surgery is the same. So we can't explain why we're seeing so many later onset seizures. Auras are common and they occur in isolation. I think this is a characteristic of hippocampal epilepsy because seizures in this area may not propagate or propagate slowly. So if patients have auras that always progress to bigger seizures, then I would question whether this is in fact the diagnosis. Secondarily, generalized seizures occur infrequently because the anti-seizure drugs that we have are good for treating generalized seizures, but not for limbic seizures. They often remit for several years during adolescence or early adulthood, which means that when they come back, there's a reluctance to believe that they can't be stopped with further drug treatment, which unnecessarily prolongs referral for surgery. If they do come back, seizures usually become medically intractable, and interictal behavioral disturbances occur as a result. The aura is usually present, most commonly epigastric rising. The focal unaware seizures begin with arrest and stare, or elementary automatisms, and posturing of one upper extremity can occur contralateral to the site of ictal onset. And the post-ictal phase includes disorientation and memory deficit. The neurologic exam is usually normal, except for recent memory deficit, which is material specific. So these patients are, if you can stop their seizures, they should be able to go back to lead normal life. The previous talk went over the EEGs, but in this syndrome, if you use basilar electrodes, in this case, they're sphenoidals. We don't use sphenoidals very often anymore. You can use true temporals or earlobes. You see a very characteristic theta pattern at the onset. And sometimes, as you see in the bottom, the onset may be bilateral, but within 30 seconds, if it becomes localized to one temporal area, that's just as localizing. The most characteristic finding, as you all know, is hippocampal atrophy, but the previous speaker showed that even in the early cases where there's no atrophy, you can see hypometabolism on PET. So if we see the hypometabolism on PET of one temporal lobe, that corresponds with the interictal and the ictal EEG findings, and there's no other confounding findings, and neuropsychological testing fits, patients have a surgically remediable syndrome and can go immediately to surgery without requiring invasive studies. Bottom just shows ictal spect. The inner ictal spect is not so localizing, but ictal spect can be very useful. So for the focal epilepsies, they can be lesional or hippocampal sclerosis or cryptogenic. Cryptogenic refers to those patients where we know that the onset is focal, but the MRI is normal and there's no history to suggest what the cause of that is. But it's important to understand that there are lesions you can see on the MRI that are not necessarily epileptogenic and are just incidental findings, like this venous angioma, which is not epileptogenic, although it might be associated with focal cortical dysplasia, which is. Cavernomas and neurocystic cysticercosis cysts are also incidental findings and don't necessarily indicate the epileptogenic lesion. On the right is schizencephaly, just to point out that you can have patients with diffuse or multifocal lesions on MRI, like tuberous sclerosis as well, where seizures just come from part of the abnormality, and they're still surgical candidates. But that's not surgically remediable syndrome because they require invasive studies. The cryptogenic focal epilepsies are usually neocortical, and we have no idea what the causes of these are in most cases, where the pathology turns up normal. But when you have an MRI that is equivocal, PET scan on the right can show an area of hypometabolism, as you see in the lower left corner of that image. And MEG can show that the spikes, the interictal spikes, are in fact coming from that area. And if you look then at the MRI, you can see that there's a bottom of the sulcus dysplastic area with a transmantle sign pointing to a small area of focal cortical dysplasia, and these patients do very well with localized surgery. So this is a surgically remediable syndrome. We have a lot of problems in this country with referrals. There's fear of surgery, lack of information about improvement, and epilepsy surgery is expensive, but surgery is less dangerous than continued seizures. There's a lot written now, so there is no lack of information. Surgery is expensive, but not as expensive as a lifetime of disability. And we now have 3 randomized controlled studies, the last of which was actually in India. There are a lot of misconceptions that prevent patients from being referred. You don't need to try all drugs. Bilateral EEG spikes doesn't mean bilateral epileptogenic regions. A normal MRI is not a contraindication to surgery, nor are multiple or diffuse lesions, as I showed you. We can do surgery if primary cortex is involved. Lesionectomies can be useful. Memory is an issue, but not if there's already a memory deficit, and I'll talk about that in a minute. Chronic psychosis and a low IQ are not contraindications to surgery. And we have a problem in this country, and maybe also in India, that some patients are being operated on in community hospitals because they have lesions without adequate workup. And as I indicated, the lesion isn't necessarily epileptogenic. This just shows you the surgical results over the years. For limbic epilepsy was 55% seizure-free in 85. At the later, it's up to 80%. For neocortical resections, the results are just as good if there is a lesion present as in hippocampal sclerosis. So verbal memory decline is more noticeable than nonverbal. So the concern is when surgery is in the language dominant hemisphere. It's likely if memory is normal preoperatively, but usually not a problem if a deficit already exists. And it's more likely if the seizures are not controlled. Adverse effects, the morbidity is usually not permanent. Mortality from surgery is 0, essentially. And I'll talk about the memory. This is an interesting study done by John Langfit of 138 patients with 2 to 5 year follow-up. 82% were in remission, and quality of life was improved whether or not memory declined. So these patients considered decreased memory a fair trade-off to become seizure-free. Of the 18% who were not in remission, if there was no memory decline, the quality of life was stable. But in the few patients where there was memory decline, the quality of life declined. So the problem then is patients who have surgery in the dominant, language dominant hemisphere, who have a memory decline and are not seizure-free. And that's where quality of life fails. And that's the situation you want to try and avoid. There was a practice parameter published in 2003 by the American Academy of Neurology and the American Epilepsy Society. Just briefly, this is based on the WEEB randomized controlled trial. And what they concluded was that patients with limbic seizures should be referred to epilepsy surgery centers if they're drug resistant and operated on if they meet criteria. This had no effect really on referral of patients in our country, which is still problematic. More recently, the ERSET study which looked at patients operated on within 2 years of becoming refractory. So it's early mesial temporal lobe epilepsy. And the results found that 73% were seizure-free in the surgical arm and 0 in the medical arm. But if you looked at the group where all the data was present, 85% were seizure-free. And quality of life was better, socialization was better, and the adverse events were mostly in the patients who didn't have surgery. So in our country, this is still highly underutilized. We figure we have 100 to 500,000 potential surgical candidates, and maybe only 2,000 procedures are done a year. And patients are operated on an average of 22 years after after onset of epilepsy. And there's been no change in referral pattern as a result of all the work that's been done in recent years. Sorry about that. This last slide is just showing the data that I have for India, indicating that you have a lot more patients, obviously, than we have. But you're making much more progress. In the last few years, there's been a 2 to 3 times increase in surgical procedures. So I think you're doing better than we are. So that's my talk. I don't know whether you have...
Thank you, Dr. Engel. Will you be staying with us for a few minutes for any questions?
Yeah, you can go ahead now if you want.
Dr. Ashekar, can I make a comment?
Please.
If it is okay with Dr. Brajesh Udani, we can go ahead with the discussion of the first 3 talks now. And after the discussion, we'll start with Dr. Brajesh talk, if it is okay with him.
I have no problem.
Bhaskar,
No problem.
Yeah, Bhaskar, can we just finish the questions for Dr. Engel so that he can carry on with his day?
Sure.
Milind, do you have questions from the audience?
So there has been some question coming up regarding certain more clarification regarding which patients with temporal lobe epilepsy should be taken up for surgery. I'm sure these questions are answered as we speak, and Bhaskar, when he's going to talk in terms of temporal lobe epilepsy surgery, he'll be covering that in further. So,
so
apart from that,
Dr. Engel,
no other element.
Yeah. So, Dr. Engel, if I may, so what do you suggest is the way forward? Because the picture you paint as far as the number of referrals is concerned and the delay in referrals is quite depressing. In spite of all that, the science that has been thrown at it, it doesn't seem to be producing results. So is there anything else we can do, or should we do something different?
Well, in this country, I think part of the... Can you hear me?
Yeah, we can.
In this country, I think part of the problem is that we've been promoting surgery too strongly. I think that there's still a resistance among primary care physicians and a fear among patients, and that the message should be changed. And to say that any patient who has drug-resistant epilepsy, where the seizures are interfering with their quality of life, should be referred to an epilepsy center for a second opinion by a team of multidisciplinary specialists, and that they deserve this second opinion, and then let the centers decide who's a surgical candidate. The problem is that the referring physicians think that it's their job to decide who's a surgical candidate. They think their patients aren't surgical candidates or don't want surgery, so they don't refer. We need to make the case that epilepsy centers do much more than surgery, and we have a lot to offer to all patients who are drug resistant, and that all patients deserve to be referred to a multidisciplinary full-service center for a second opinion. In India, I think you have so many patients who are clear, have clear surgically remediable syndromes that you could spend all of your time just operating on them. And I understand the problem is that you have to operate on patients who come to you, even with the most complicated cases. So you can't focus just on the simple ones. But raising consciousness in the community about surgically remediable syndromes should increase the referral of patients who can really be operated on without a lot of invasive studies or other complicated approaches, and with very good results.
Thank you.
Dr. Rajshekhar, can I ask one more question?
Please.
Good morning, Professor Engel. I'm Dr. Bhaskar.
Hi.
You mentioned this point, and there is a tendency among young neurosurgeons to do lesion-oriented epilepsy surgery. Now, to shift the focus to focus-oriented surgery, what are your tips or guidelines? More electrophysiology-based surgery for the surgeons?
Well, the previous speaker, from what I saw, talked about the pre-surgical evaluation, and it's necessary to do a full pre-surgical evaluation on all patients who are operated on for epilepsy, and not just remove a lesion, because the lesion may just be an incidental finding. It's very difficult to convince people who, neurosurgeons out in the community want to operate, and they see these patients with seizures and they see a lesion and they take out the lesion. That has to be discouraged.
Thank you.
So, Bhaskar, can we take questions for Dr. Radhakrishnan and Dr. Rathod?
Yeah, I think as long as it's okay with Rajesh.
Yeah, he has
Okay.
said it is okay.
Yeah.
So can I leave you, and thank you very much for letting me be part of your conference. I'm sorry
Thank
that
you.
Thank you, Dr. Engel. This is Dr. Kurupat. Good to see you. Bye.
Yes. Okay, I'm sorry that I can't be there. I would love to be there, but I understand you're having a lot of problems with COVID, so I hope you are staying safe and keeping well. All right.
Thank you.
Bye-bye.
Thank you.
Thanks.
Bye-bye. Good to see you. Good to see you again.
You need to stop sharing your screen. Okay. Yeah, well done. Yeah, okay.
Milind, any questions for Dr. Radhakrishnan or Dr. Rathod?
Actually, no, nothing from the audience, but I must tell you that we have about 357 people listening to what we are speaking. So it's quite encouraging.
Oh, that's a good number. So can I ask Dr. Radhakrishnan a question? I think both Dr. Engel and you have emphasized the need for increasing awareness. And what I gather from Dr. Engel's answer to my question is that the messaging might be wrong, actually. The messaging, and as he put it, it is coming across as too much of pressure being put on patients to get operated, and so we shouldn't talk about surgery. At least not we, but the primary physicians and the neurologists also probably who see them out in the community should not be talking about surgery straight away and say more evaluation. I think that's a very important message. If
I fully agree with him that I think there is a saying that which I learned from Mayo during my Mayo days, and epilepsy surgery is something that which you should not be selling it, but you ultimately make the patient to buy it. So that is a kind of the dictum we should go. That initially, I think it is what we are telling is nothing untrue. For example, if the patient is drug resistant or non-responsive to anti-seizure medications, which in our country are primarily seen by the non-neurologist initially, they should know when to refer these patients, how to diagnose drug resistance. A few years ago, nearly almost a decade ago, we did a study on the primary and secondary care physicians in one of the Indian the Medical Association meeting. We gave them a questionnaire to find out how many of them were aware of epilepsy surgery. There is something called surgical treatment for epilepsy. It was only 18%, something like less than 20% of them knew that there is something like epilepsy surgery available. So I think primarily because most of them are not aware, and then they may readily agree for a referral for surgery when there is a brain tumor, but not for epilepsy. So that primarily they should be told that when to diagnose drug-resistant epilepsy and why they should refer these patients for a comprehensive evaluation to find out the cause of why they are non-responsive. And it is up to center to decide whether they are ideal surgical candidates, whether the patient could wait, or whether the surgery is totally deferred, or alternate treatments are available, like modification of the medicine alone might be beneficial for these patients. So at the primary level, even from the neurologist side, when they are referring to the comprehensive epilepsy program, they refer to find out, as Dr. Enkel put it, a second opinion to find out the cause of the drug resistance, rather than the treatment option is decided then at that level. Then they need not even refer those patients.
Thank you, Dr. Radhakrishnan. So if I may ask Dr. Rathod, thank you for that. You are muted.
Yes, sir. Please,
okay. Yeah. So, thank you for that very clear, presentation on the levels of evaluation. If I may ask you a question about the difference in your practice. You have seen the practice in Sri Chitra. You have been part of the team there, and now you are in a, if I may say, slightly different environment. Maybe you have all the facilities, but it is definitely different from what it was in Sri Chitra. So what is the difference, and sort of has it made any sort of real difference to the patients as far as outcomes are concerned, or do you think wish you had this facility, or are you missing anything? If you can sort of elaborate on that.
Yes, sir, I got the question.
Can I just interrupt?
No, there is a difference of the day and night. Sri Chitra, where I was working earlier, was a tertiary referral center, and every patient who is coming to Sri Chitra, we will be able to offer everything under the sun. And another important aspect of the patient coming to the Sri Chitra, that they will know that, okay, now they are come to probably the final destination, and whatever we are going to tell, they will accept it. And the patients in Sri Chitra actually will ask for the epilepsy surgery rather than we trying to convince it. So that was a different concept. Here, which I am working, is a very basic facility where I have a video EEG which I have established, and the MRI. I don't have a trained neuroradiologist, so all the training I received, so I read my MRI by myself. I have to send the patient for 3 Tesla MRI and for PET scan outside. But all this, with this all limitation, and I don't have a neuropsychologist to assess really. Even with this limitation, as I pointed out, those surgically remediable syndromes can be very well operated, and which usually forms the bulk of the epilepsy surgery. So although I regret that I may not be able to offer a stereo EEG to the patient, or mainly the intracranial EEG, which may not be feasible in my setting, but majority of the common cases which require surgery and in the community, I am able to offer. So in that respect, there is no change, but obviously it depends upon the person who is trying to establish the program, sir.
Thank you, Dr. Rathod. I think that's very encouraging to all the attendees, young people who want to start the epilepsy surgery program. Sorry, Milind, you were saying something before we go on to Dr. Udani's talk?
Yes, I just want to try and let's conclude this and get on to the next.
Yeah, so that's what, this was the last question, yeah. So we'll move on to Dr. Udani's talk. Sorry for keeping you waiting.
Not at all, not at all. There's no problem.
Please go ahead.
Can you see my screen?
Yes, we can.
Yeah, we can.
Yeah, I mean, I chose this topic because primarily I did not want to, repeat what Dr. Rathod had already said. And the only things I want to focus on are young children and infants, where I seem to have some experience in this group. I must admit that these patients are difficult patients usually. Some of them are simple. There are many technical problems, there are many difficulties in MRI reading and evaluation of different semiologies and EEGs, etc. Not moving. Okay, so what we had to basically decide is what evaluations help in deciding when to avoid surgery, which are the ones to consider surgery early, and then of course MR, imaging, video, EEG, and the usual stuff. Neuropsychology has limited usefulness, and I'll just talk about it if we have the time. So pre-surgical evaluation in young children, drug-resistant epilepsy, yes. But remember, in kids, there's even more reluctant parents who want to come for surgery. And they're scared of doing it on themselves. They're even more scared of doing it on the young kids. And they have very appropriately, they resist surgery for a long time. We try to maybe use 3 drugs, even though the ILA says 2, to try and sort of convince them that this actually, and we try to push it really hard when cognitive and intellectual deterioration is a significant risk of it's already occurred. Of course, unifocal lesion epilepsy is always fast-tracked. And the most important thing is we have to exclude certain epilepsy syndromes which look drug-resistant and where obviously epilepsy is going to fail. And this I'll just show you some examples. For example, this is a child with benign epilepsy of childhood, and usually comes the very benign course, happens in focal seizures over here, typically EEG. But in about 20%, 10-20% or so, the evolution is severe. They have drug-resistant focal seizures, drop attacks, and new onset progressive disorders. Even though it's called benign, it's not really benign. And then sometimes people might evaluate these patients for surgery. But remember, it always disappears by teenage years, and obviously it's a mistake. This is a 17-year-old boy, had a motor seizure on the right foot. I've just taken pictures because of a long seizure. And as you can see, there was a starting in the right foot. He's already got a right hemiparalysis, and the seizure remains on the right. And, it looks like it's coming from the region of the leg motor area. And the EEG also seems to help. There's a midline discharge interictally, and even the EEG over here seems to start from the midline areas, which is exactly where we expect the leg motor region to be. However, there is no change in the MRI. Multiple MRIs had been done, and the PET showed hypometabolism, which is bilateral. So here we had a situation. What should we do? Should we do EEG, implantation, etc.? It was discussed in many conferences. Finally, we did the genetics, and there was a mutation in the SCN1A gene, which is a sodium channel gene, and which seems to have horrible results if you subject them to surgery. We just controlled the anti-seizure drugs, and the patient became seizure-free. So genetic evaluation may be something which should be considered when you're having young children, or at least children with early onset of epilepsy who are MRI negative. What about video EEG? A lot has been talked about semiology, etc., and EEG. And as Professor Rathod has mentioned, it's very important in adult epilepsy, but may not be completely true. And sometimes, of course, it's easy. Again, I've taken pictures. I have the video, but it will take a long time in the interest of time. So the video SSA shows a 15-month-old, and this is how he starts. He starts looking to the right, and this lasts for at least 1 minute or so. And after that, the eyes deviate to the left. So sometimes it is right, sometimes left. Sometimes it starts from the, it's difficult to be sure from the history. And, we did the EEG. It was simple. There was a single polyspike discharge in this, which you can see in the occipital region. And it seemed to, start from the left occipital region and then spread on the left side. So it appeared that everything was concordant like you see in adults. I mean, occipital seizures typically come with ipsilateral or contralateral eye deviation, and this, of course, appears to be left occipital iris. But before we go to the other investigations, I'll show you that later. But basically, that will illustrate the problems of MRI and other investigations in these children. So this seems to be a fairly easy case, at least electrophysiologically. But then you look at this patient, and you find that it starts off with what looks like ocular spasms. Suddenly we'll go on to have, there's the ocular spasm, comes in clusters. You're having some chewing movements. And again, it'll happen. There it is. And after about when this started at 6 months, and about 10 months or so, he started having cluster of extensor spasms. All these appear to be very generalized, usual kind of seizures which you see in the infant. And these extensor spasms are clusters of jerking, which occur either in the flexion or extension, and happens usually when they awaken. There it is. And happens again several times. And it's only at 3 years of age, this all had disappeared, and the child now had, it doesn't seem to have started. I'm sorry. Anyway, this seems to be a focal seizure. I can't seem to start. Here it is. Okay. The focal seizure, which starts when the baby is sleeping, starts having motor automatisms of the mouth, oromo-elementary automatisms, and then stares, has little ipsilateral deviation of the eyes. The right hand becomes dystonic and has focal seizures. So first the ocular spasms, then extensor spasms, and at 2 years has focal non-motor seizures, which seem to coming from the left posterior on the EEG. Initially, EEG was generalized and was not shown, but the MRI showed a possible epilepsy. The iris show you that, but not really sure. And this is exactly what happens. You have the MRI, which is showing this little asymmetric myelination. The right side is clearly myelinated, the left side is not. You suspect that the problem is over here. You do a SPECT and a PET. This is an interictal PET, and you can see a nice hypermetabolism, which lights up. And this patient, of course, gets a left TPO disconnection and does very well. The point of showing this is that it is evolution of the semiology, which will make it difficult to have a surgery in the first year. The difficulties in MRI evaluation as well. Again, I'm showing you a picture. I'm not showing the video. And this is a child who's 6-year-old. First, she has TS, tuberous sclerosis, has a drop attack, has the only seizure type. And if you look at the EEG, it is really generalized. Of course, she has a big tuber, which is calcified and which has a big hypermetabolic area. And in spite of the semiology, which is generalized, a little asymmetry, and the EEG, which is also more or less generalized, based on the MRI and the PET, etc., we decided to go ahead, and now she's seizure-free for the last 1 year. So what I'm trying to say is that infants, if you look at generalized seizures and undetermined seizures, where you're not sure where the epileptic zone is, whether it's focal or not, because remember, epilepsy surgery, resective surgery is really meant for focal, when you can demonstrate a focus. And if you see this, between 1 month to 3 years, many of them are undetermined. Between 3 to 6 years, some few are less, more chances of generalized epilepsy. And later, of course, the focal seizures come up. So when you look at these children who are under the age of 8 years, focality is not very clearly demonstrated by semiology, like in adults, while in above the 10-year group, it sort of becomes more like adult, and therefore pre-surgical evaluation at that time would be typically like adults. So semiology is not always used in deciding the epileptogenic zone. And this was a very old paper now. And what they found was that semiology as well as generalized EEG findings, this is typically for generalized EEG findings, did not really change the seizure freedom in patients with early developmental lesions. If you had tuberous sclerosis, if you had cystic encephalomalacia, if you had malformations of cortical development, you could have all sorts of seizures from both sides multifocally and still have a focal resection having seizure freedom, which is similar to those who had localized or lateralized EEG findings. What about MRI, nuclear imaging, the usefulness and the limitations? So, of course, this is lesions which already have been shown before, which beg early posterior surgical evaluation, usually picked up by a good quality 1.5 Tesla. But these are difficult cases. So even though you might pick up a hemimegalencephaly, it's not easy to do this in a young child with ease. So it needs to go to a higher center. Rasmussen's, yes, easier done. Then you have focal gliosis, ganglioglioma. So all these are straightforward cases. These are hemispheric lesions, and these are, of course, focal and very easily treatable surgically. Where most people are reluctant to offer resective surgery, like Chhatrapati himself said, you don't want to, have bilateral lesions which are typical of hypoischemic encephalopathy at birth or hypoglycemic brain injury. And generally, you tend to, these patients have generalized disorders, even though the MRI might show more focality. People have started doing invasive recordings to help these patients, but generally, I try to do minimum PSCs, especially if I'm considering palliative surgeries like callosotomy for drop attacks or neuromodulation procedures like VNS. What about the epilepsy protocol? When you ask for epilepsy protocol, most neuroradiologists do a temporal lobe obliques. And that is not what we're looking for in young children. So, and it changes with the age. This is more than 2 years. This is less than 2 years. To summarize this, 3D flare and T1 is more useful in older kids. So flare is generally sometimes unreliable in younger kids, and 3D T2 is much more useful in infants. So when you ask for an epilepsy protocol, you're not really looking for hippocampal sclerosis, which is really isolated HS, is rare in kids and usually comes as part of dual pathology. Like, for example, this child who has a malformation over here and hippocampal sclerosis both. And you're looking for subtle lesions. This is the transmantle sign of focal cortical dysplasia or the bottom of the sulcus. So this will be picked up by 3D flare in T1 in older kids and in T2 in younger kids. Sometimes the EEG looks so terrible that you wouldn't even think that this patient would be a surgical candidate. So this is a 2.5-year-old who had generalized spasms. Twice the MRI was normal and well done MRI. Genetics was normal. There was hypsarrhythmia initially controlled. And then you look at persistence. When the baby was seizure-free for a few months, there was persistence of changes over the right posterior cortex. And this showed that there was something going on over there, and we had to search for it. So the interictal EEG is definitely more informative after you control this terrible epileptic encephalopathy. You look at this, we did a PET scan, and you find that there's a lesion in the right temporal area and basically in the mesial and the inferior part. And therefore, after this, you go back to the MRI and then you look at the parahippocampal gyrus on the right, and you find it's a little different. The myelination is a little different. There seems to be a little thickening of the cortex. So in fact, what one should do is re-examine the MRI after you do a PET. So PET sometimes tells you where to look, and that's very important for the radiologist. Then you have this. There's a case which I showed the first one, the one which was such an easy one electrophysiologically. The MRI is not very clear. There seems to be some blurring of gray-white matter, a little bit of asymmetric demyelination on both sides. So it looks like there is something in the appropriate left posterior quadrant. And then you do a PET and MRI co-registration, you find very clearly a marked hypermetabolism in this area. Of course, PET seems to help in this kind of cases, helps confirm and improves your confidence of doing surgery in this patient. Like what we did in OER was a simple disconnection, and TPO disconnection should do very well. And basically, one thing you must remember that PET usually overestimates the epileptogenic zone. What about SPECT? I mean, we heard a lot about that. And this patient, of course, has multiple lesions, TS. This is an old case. And you can see that the EEG is something on the right, rectal EEG, which suggests that this is the tuber. You do an interictal SPECT, simple one, you see the hypometabolism. reduced perfusion over the right frontal region. You give the ECD and you find there's a bright uptake over there. And a simple surgery of this. So simple surgeries can be done even in patients who have multiple lesions like DS. Of course, there are many more other methods of treatment of this, and we can't go into that in a short time. What about, can you improve the SPECT quality? How can you, for example, this patient, if you look at it, it looks pretty normal. It has, it's thought to be a right sort of frontotemporal epilepsy from the EEG. But if you look at this very clearly, you find there's a slight thickening in the right insular anterior insula, which appears to be seen on the flare as well. And then we do what is called a syscom, where you take the interictal and the ictal PET and you post disturb with the MRI, and it localizes somewhere over there, suggesting that this is probably right, and there is a right insular dysplasia. This patient would really be benefited by surgery. Sometimes interictal PET may confuse, because usually when you see interictal PET, you expect hypometabolism. So in this patient had refractory spasms, had drug-resistant focal status, and came in a coma, had this hypermyelination, which is, the myelination at this young age. It should be more, on T2, it should appear bright. Over here, there's a clear darkening. So there seems to be increased myelination. And this is a sign of dysplasia, which actually disappears with time as myelination becomes more symmetrical. And the PET scan which you see is actually hypermetabolic PET. So usually you get a hypermetabolism, so it might confuse you. So you might think it's an interictal PET, but this patient has continuous seizures going on, which is the reason why he has a hypermetabolic PET. What about language and visual other functions? We try to find out in adults. You know very
Dr.
well.
Udani, can you conclude, please?
Yeah. So you're using this kind of functional MRI, but it's difficult to do in children. So what we've been doing is DTI, or diffusion tractography. See, for example, this is a patient who has mild hemiparesis. It is clearly showing that the contralateral motor tracts are clearly atrophic, and therefore this patient will do quite well even if you do a hemispherectomy. This is another patient who's right now admitted for hemispherotomy, and we found that the tracts are fairly symmetrical, so we expect severe hemiparesis. The last thing about this, the last two slides, the DTI can also be used for, this is a 2-month-old who we did for surgery, and we found that there was a relapse of surgery, so we did a DTI post-op, and we found that the corticospinal tract on the right was still not disconnected, so we had to go in again. So DTI seems to be very useful to assess whether disconnection is complete. Last slide, the neuropsychology in this age group is not really helpful. It's only as a baseline to track the changes, and usually you can only use different scales like adaptive scales at this age, and therefore very low pre-op scores, remember, is not a contraindication. So summary, semiology often motor and non-naturalizing, non-localizing. It evolves over the years. Interictal EEG, unlike adults, has limited utility in young infants with developmental lesions and may sometimes mislead. MRI sequences in the age should be tailored depending on age. Advanced MRI helps in unique ways. And of course, PET SPECT with post-processing techniques reduce the need for invasive intracranial monitoring. Thank you very much for your attention.
Thank you, Dr. Udani. We'll take the discussion at the end of the whole session. And so let's move on to Matthew. And he'll be talking on surgery for focal cortical dysplasia.
Thank you, sir. First of all, let me thank Bhaskar Rao sir for giving me this opportunity. Is my screen visible?
Yes. Go ahead, please.
So focal cortical dysplasia, I'm going to deal with purely the surgical management of it. I will not go into the workup of these lesions. Focal cortical dysplasia is a spectrum of conditions which often presents with refractory seizures. mental retardation, psychosis, and autism. In fact, 40% of all seizures that appear in young age patients is because of focal cortical dysplasia. It was first described by Taylor, who had noticed the balloon cells in 1971. To get a real idea of what is cortical dysplasia, we have to recapitulate our...
Sorry, Matthew, your slides are not moving. Yeah, you need to...
My slides are not
moving. Go to the presentation.
Yeah, put it on the play mode and move your slides, please.
Now?
No, you need to go to the slideshow, Matthew.
Play.
No.
Now are they moving?
No.
Nothing.
No. We are still on the first slide, the title slide. So there is a play right on top. Do you want to use that? I don't know. This is a Mac.
Yeah, your
screen, Mac.
Yeah, well, it should play on Mac. Should not be an issue. Why don't you just put it on the slideshow, Matthew?
Yeah, 1 minute. I'll stop share and then again come back.
Yeah.
Share screen.
Yeah.
We can see now.
Can you just go to the next slide? Just go to the next. Yeah, it's moving now. Great.
It's moving.
Yeah. Okay. Perfect. Yeah.
So it was first described by Taylor, who had noticed the balloon cell in 1971. To have an understanding of cortical dysplasia, we have to recapitulate what we know about the structure and development of the cortex, without which this will look like Greek. Now, we all know that the cortex is a 6-layered structure, and most of the functions are organized in a columnar manner, in a vertically oriented column. If you see the cortex develops from a telencephalic vesicle. Is my pointer visible?
Yes.
Yeah. So this is a telencephalic vesicle. The dorsal aspect of the telencephalic vesicle develops into the cerebral cortex. The cells actually originate from a single layer, pseudostratified single layer on the ventricular surface. So the basic cell is a neuroepithelial cell. This goes on dividing, duplicating itself and creating a large number of copies of itself, and then evolves into the something called the apical radial glial cell. This apical radial glial cell has a capability of duplicating itself and also has a capability of an asymmetric division to form neuronal cells. There is also a possibility of forming something called an intermediate progenitor cell, which will actually divide and form 2 neurons. This entire mechanism is actually for excitatory transmission, and the cells are all glutaminergic or cholinergic neurons. The apical glial radial cells can actually transmit or guide these neurons into their appropriate position. The whole pattern is that the later formed cells go to the very border or to the margin or to the marginal zone, while the earlier cells remain in the deeper layers. Suppose you are in the case of a lysencephalic brain, that is a lower mammal, the pre-placental earlier mammals, this is all that the mechanism that's required to create the excitatory columns of the cortex. The cortex is actually flat. But when you come to a gyrencephalic mammal like humans or apes, or even some of the rats, you will find that there is another set of basal radial glial cells. They do not have an apical region, but they remain they will grow up to the subventricular zone. But otherwise, their potential for forming neuronal cells or progenitor cells, intermediate progenitor cells, is the same. They have an accelerated rate of growth in comparison to the apical radial cells, and they expand in a much larger proportion. They are detached from the basal layer, and so they form something like a mushroom, resulting in the formation of the gyri. Once the cells reach their definite location, there is a process by which they mature. They become evolved branches and dendrites, and you have this form of a pattern that is formed. So this gyral formation is actually not because of any mechanical factors, but because of a pre-programmed growth. It is controlled totally by genes as well as by regulatory proteins which are found in the CSF. At this stage, these neurons will form synapses. This is a very elaborate process, again controlled by genes. It forms hundreds of synapses, hundreds of perhaps even thousands of synapses, and they will form interdigitate with other nerves, other neurons. Along with, synchronous with this process, we will find on the ventral part of the telencephalon two eminences, that is the medial and lateral ganglionic eminence. From here starts the inhibitory GABAergic neurons. They form two streams that flow in a tangential manner into the subventricular zone and into the marginal zone. We should not think that this is limited to this area. This greatly adds to the sophistication of the cortex. As they move in, anywhere they can turn along the radial glial cells and interdigitate any neuron. So this parallel interdigitating mechanism ensures that inhibitory interneurons can reach anywhere. And the entire process is predetermined and to a good extent genetically programmed. Now, if you see, if there is a lot of possibility for malfunctions or maldevelopment in this entire process. We know that there are a lot of steps involved: the proliferation of the neuroepithelial cells, the formation of the apical radial cells, tangential as well as radial lamination, the apoptosis. There's a continuous process of apoptosis going on in both types of cells: apoptosis, gyral formation, and synaptogenesis. And any defects in this entire, anywhere in this process will result in some form of cortical malformation. And when there is a domination of excitatory activity as part of a malformation, there will be a shift towards epileptogenesis. And this is the foundation of most cortical. This is actually the basis by which cortical dysplasia produces seizures. The most comprehensive classification of cortical dysplasia is by Barkovich, in which he has classified it according to the disorders of proliferation, disorders of cellular migration, and disorders of post-migration cortical development. Our topic, that is the focal cortical dysplasia, is distributed in two regions. It may be because of abnormalities of proliferation, or it can be because of disorders of post-migration cortical development. There are several classifications of cortical dysplasia. However, I think the most favored one is the Blumke's classification, where it is divided into type 1, type 2, and type 3. The type 1 is because of FCD with abnormal radial cortical lamination. Type 1B because of tangential cortical lamination. Now, in the background of cortical development, this appears a very logical way of understanding it. Without a background of cortical development, you will find this very concept of even classifying is a little confusing. And the type C, when there is abnormal radial and tangential lamination. Along with this, we should also understand that there is minor changes like microdysgenesis, where you may find only 1 or 2 neurons that are abnormal. You may not get the whole lamination changes. In this, actually, what you get often when there is of radial lamination, you just see microcolumns of neurons lying within the cortex. And in other places, you will find a bizarre arrangement of neurons when there is a tangential lamination problem. In type 2, you have the dysmorphic neurons, which are very obvious. large dysmorphic neurons type 2A, and when you have the classic balloon cell, you call it type 2B. And the FCD type 3 is actually secondary FCDs, which may be seen in hippocampal sclerosis when there's a tumor or when there's a vascular malformation. First of all, for the management of cortical dysplasia, you have to understand that it's a special entity. And the parameters that they use to manage routine neurosurgical cases cannot be applied in cortical dysplasia. In the beginning itself, the first problem that you're likely to face is the difficult imaging correlate. You'll find that there may be an abnormal sulcus. This is actually a posterior quadrantic dysplasia. You may find a loss of gray-white differentiation here. Here there is a thickening all along the insula as well as into the subfrontal region. Or you may have the classic this transmantle sign, that is where you have a streak of cortex going vertically down into the white matter. You may have just an absence of a gyrus. This gyrus is just absent or not formed. And perhaps the most commonest type of radiological abnormality that you see is just signal alteration in flare. This actually forms almost 2/3 of all radiologically visible cortical changes. When it comes to operating on these lesions, again, there are a lot of problems which the neurosurgeon is routinely not faced with when he deals with other conditions. First of all, it's difficult to identify on the cortical surface. Everything will look same. There may be some degree of atrophy. You may find some thickening of the arachnoid, but ultimately you will not see anything very definite there. So you require a higher level of imagination as well as using many other accessories to really locate it. Very often there may be an extensive field change in what you see on the imaging, or maybe on an ultrasound, or even on following a corticography, maybe only the tip of the iceberg. So you expect it to be a much wider entity, and you use more of your resources like deficits, neuropsychological dysfunction, the information you got from corticography, from intellectual recording, to imagine or visualize where the lesion is. You cannot follow from routine what you see on under the microscope. Very often there will be functional overlap with the lesion. Unlike a tumor, a proper tumor is tumor only. While in a dysplasia, you may find interdigitating or overlapping function. And deep white matter extension may go down to the ventricle, right through the eloquent white matter, but very often this may not generate seizures. Because of the high intrinsic epileptogenicity of the lesion, dysplasias demand themselves to be totally removed to get a proper seizure outcome. It is because of the imbalance between the excitatory and inhibitory neurons. So they themselves can generate, if they are linked to any other tissues, they can generate seizures. So they need to be fully removed. And another problem is that imaging may underestimate the extent of the lesion, as we have already seen. And sometimes a post-ictal MRI may overestimate the lesion. The post-ictal changes may be more extensive, and you may not be able to really predict where the lesion is. And another issue is that you may find a fixed deficit, but it may be actually be a Todd's palsy. This is also one of the confusing points. So the first way is to go for a wider craniotomy. There is no role for a minimally invasive or a small craniotomy. You're going to apply all your resources. You're going to use ultrasound. You're going to use corticography. You may have to the feel of the lesion, so many aspects. So maybe you may have to come out with a large grid if you're not able to make out anything during the procedure. So wide craniotomy is preferred. Corticography is useful. The corticography may not show maximum spiking in the center of the lesion, but towards the periphery, you may show spiking. It has to be interpreted in the background of other things, and you need not become a slave of corticography, but it is a very important adjunct when it comes to cortical dysplasia. The functional, we all know how to tackle functional overlapping. You can go for a wave craniotomy. You can go for extra operative stimulation with a grid. Your technique has to be precise. You have to preserve every blood vessel. You use a subpile technique. All these are the methods by which you can preserve function. When the lesion is extensive, an effective seizure reduction may be obtained sometimes when you have even do a small removal. To get the feel of what is cortical dysplasia, I will just illustrate 2 cases to you. This 2-year-old boy had seizures since 6 months of age, complex partial seizures with frequent generalization. The frequency as well as the severity went on increasing to the extent that he had 30 seizures per day and several generalizations. You can see that all along the insula, you will find that there's a gray-white differentiation loss from the subfrontal. So this, the insula, as you see, is a relatively less accessible zone. Now, how do you tackle this? So this is I am opening the insula. There is no role for actually a minimalistic approach in cortical dysplasia. You are bound to be radical. Unless if you're radical, what will happen is you may produce some deficits and the patient may not get benefit by seizure freedom. So if you see this, you can see that I'm exposing the limit insulae as well as the MCA and its divisions. I'm not satisfied with that degree of exposure. I'm going posteriorly. I'm exposing the entire insula. I'm going to the posterior limits where I'm seeing the angular artery starting coming. So the whole insula is now exposed. You can see the long and short insular guy, right? So this is a very extensive exposure that I've done. And I'm starting to remove the lesion. So this is the postoperative scan. You can see the entire insula has been removed. There is no role of leaving a small portion of the lesion out. And this patient did reasonably well, at least for a significant duration of time. So we have in Chitra, we have operated on 219 patients with cortical dysplasia. And I'm just presenting a small study that we have done with a 10-year follow-up of 38 patients. The mean age of the sample was 26 years. The mean duration of seizure was 7.4 years, and the youngest patient was 11-month-old. Hyperintensity on flare was the commonest imaging finding, 74%. An abnormal sulcus was seen in 22, and a distortion of the gyral pattern in 5, and a transmantle sign was seen in a minority, that is approximately 7 patients. 80 lesions had eloquent overlap. That means very significant number of them, almost half of them, there was an eloquent overlap. 6 awake craniotomies and 22 replacements were done. 2 hemispheric disconnections had to be done because the cortical dysplasia was extensive and there was little function to preserve. And the opposite hemisphere was normal. 27 patients underwent gross total resection and 7 patients had fresh deficits. That is, 7 of the patients developed new deficits, but all remained independent for daily activities. This is a balloon cell that we got in one of the patients. Dysmorphic neurons were seen in 12 patients, with balloon cells in 7, and a ganglioglioma was seen in 1 patient. So this was our outcome. This matches with most of the literature. The overall seizure outcome was good in 23 patients, that is 60.5. And that means around 40% did not have a good outcome. 6 patients had substantial reduction of seizures. 23 of the 27. So whenever we got gross total resection as part of, as judged by the surgeon, we got a good outcome. 23 of the 27 patients got good outcome when they were gross totally removed. And 6 of the 7 patients with balloon cells. So when you get balloon cells, your outcome is likely to be good, which means that it is the abnormality is in the form of a column, and you will be able to understand or resect that better. So I will just present another case where we have a very confusing scenario. This 14-year-old boy had come to us with a occipital, parieto-occipital dysplasia. He had seizures which were with a primary visual aura and eye pulling, and it was definitely looking like occipital seizures. So we did a 6.5 centimeter parieto-occipital lobectomy on the non-dominant side, keeping just short of the sensory cortex. We had done an fMRI, and this is what we got. The patient became seizure-free initially, but after 6 months, he came back to us with another different pattern of seizures. This time, it was an electric shock-like sensation coming to his lower limb, followed by a fall, perhaps more disabling than the original seizure. So this time, we decided to be more careful. We did an fMRI. We found that the sensory and the motor cortex was identified here. The paracentral lobule was here. We have stopped well short of the paracentral lobule. We have put a grid on the medial as well as on the lateral side. We did prolonged recording, and we found that the seizures were rising from the paracentral lobule. With the consent of foot weakness, we did this resection. The patient developed some mild degree of foot weakness. You can see that the paracentral lobule has been removed. Again, this patient became seizure-free, but after a few months, as we started to taper one of the drugs, again a new pattern of seizure came. This time it was a hypermotor seizure with an asymmetric limb posturing, possibly through the cingulate. So here we are having something which is playing a cat and mouse game with us. This cortical dysplasia, when we remove, we find that a new area seems to be firing. That means we are unable to see, even through electrophysiology, the limits of this lesion. So to conclude, cortical dysplasia is a fairly good surgical target. The parameters that you use require to be slightly different. Total excision is the ideal management. Vague localization correlates and overlap with eloquence can be a challenging issue. And dysmorphic and balloon cells are good prognostic markers. Thank you.
Thank you, Matthew.
There is a specific question which has been asked by one of the registered users. This question is aimed at Dr. Rajesh Udani. Rajesh, are you there? Yeah.
Yeah.
So the question asked is, would drug-responsive seizures be benefited from surgery by way of drug freedom, at least in children where AEDs are associated with cognitive suppression and development?
See, it depends a lot on the pathology which you're operating. For example, in hemispheric seizures, there's a good chance that you remove the entire network or whatever it is. But the problem with, for example, cortical dysplasia is, and usually there's an epileptic network very extensive. So in general, in the past, people used to remove stop the anti-seizure drugs. But the tendency is that after a few months, in the first 6 months, of course, it's because of incomplete resection. But after 6 months, if it comes, it's probably from the network, from some other node in the network. And therefore, it's at least come down to the minimum drugs and use it. But, I know the work from Chitra has shown that you could try and remove it, and many patients do benefit, because one of the problems with Indian patients is they want to get off the drugs. But if you look at many people do get late seizures, and after some time that sort of stabilizes.
Yeah. So
can I?
So actually, in the same vein. Yeah, go ahead. Sorry.
I have a comment on Matthew's presentation and also one question to Rajesh Udani. Can I go ahead?
Yes, please.
Yeah, comment on Matthew's presentation. This is regarding David Taylor, who first reported focal cortical dysplasia 50 years ago. David Taylor passed away recently. There was an obituary written in BMJ, British Medical Journal. Those who are interested can read. That is one. And David Taylor is a psychiatrist, and his important contribution is actually coming out with quality of life scales in people with after epilepsy surgery. That is his most important contribution. This quality of life scales came only from his work, David Taylor. So very important contributions. That is about Matthew's talk. And the question to Dr. Rajesh Udani, you have mentioned several limitations of pre-surgical evaluation in young children. Now, no child deserving epilepsy surgery candidate should be denied the chance of epilepsy surgery, and no unnecessary surgery should be done. Now there are 350 participants. Can you give some tips about this case selection, when to avoid and when you recommend surgery?
See, I think the most important determinant is the MRI. Unlike in adults where electrophysiology is also very important. And this MRI usually, if it has a unifocal pathology, maybe discrete, maybe lobar, maybe hemispheric, whatever, that is the single most important, irrelevant to what the semiology may show or what the EEG may show. But the problem in most of the epilepsy we see, the ones we definitely want to avoid as far as possible, then of course sometimes we do palliative, sometimes we even try resection, are the ones with multiple pathologies. And that, for example, doesn't apply to tuberous sclerosis, which is now becoming more and more managed surgically. But in general, multiple pathologies in India are these perinatal injuries, etc. So you definitely don't want to, somebody did mention that everybody should get pre-surgical evaluation. In India, I suppose you're living in Orissa and you have to travel to Delhi and you have a patient of neonatal hypoglycemic brain injury. I would rather treat him with non-surgical means, at least for a long time before planning. So I think the most important thing is the MRI going to be.
Thank you.
So could I ask a question to Matthew, Dr. Rajshekhar?
Yes, please.
Matthew, you obviously have a very large experience at your center at Chitra with focal cortical dysplasia, which is the legacy which has been set up at Chitra now for so many years. One of the tips, if you could give to a program which is just about starting or has just started, is when do they switch over from simple, straightforward temporal lobe epilepsies, or for that matter, easy to identify surgical substrate epilepsy, and for that matter, when they have to take over cortical dysplasia surgery, because cortical dysplasia surgery needs significant workup as well. So if you could just give some hints on that.
It's an extremely valid point Dr. Milind has pointed out. Dr. Radhakrishnan actually answered this question to a good degree. The success of an epilepsy center depends on the success of your initial cases, because you are in a world where a good number of people do not believe in it, and your patients are the best ambassadors. So you can, if you start taking up cortical dysplasias as your first few cases, you're certain, I am 100% sure you're likely to get damage, or the MRI normal cases. The outcome, the best outcomes you can expect of an MRI normal patient is not more than 40%, statistically, if you see. So 60% of your patients are going to end up as dissatisfied. Cortical dysplasia as it is, I think, should start as a second or third phase. The first phase should certainly be MTS. And in a country like India, you have a huge reserve of MTS patients. And you may be tapping from something like 5%, which is coming to you as a referral. Once the confidence in your procedure improves, and also the surgeon starts learning the intraaxial anatomy, it's quite a little different from what people routinely do with tumor surgery. The intricacies of the internal, the intraaxial entity of epileptogenic zone requires a little evolution to understand, and perhaps there is no case better than mesial temporal sclerosis to learn it. And from mesial temporal sclerosis, I think the next stage is to go into callosotomy and then into hemispherotomy. And once somebody has a series of hemispherotomy, then I think one can go into cortical dysplasia. Lesional is different. If you have a tumor, if you have a very definitely visible cavernoma, only the basic principle that the cavernoma is not just a stained area, but a little more than that has to be kept in mind. But I will say it is a third stage. After you have started doing hemispheric surgeries, then maybe cortical dysplasia is a good entity. And ultimately, every large volume center has to evolve into a level that they can tackle some of the cortical dysplasias at least.
So if there are no further questions, can we wind up this webinar?
So I have an announcement to make. Can I make that announcement before you wind it up?
Please, yes. Sure.
Milind, I also have to just say a few things before closing.
Okay.
Yeah.
So I'm sure the Thanksgiving is going to be done by Bhaskar, so I'll leave that to him. But the announcement is for all the participants who have actually taken the opportunity and the time to listen to these extensive talks by these very learned speakers. We would be incorporating Bhaskar's talk in the second webinar, which is going to be on the 29th. That is the next Thursday. And obviously, I would request everyone to be present and to attend and listen to this, because everything is being aimed at anatomy and to learn, and obviously try and incorporate these practices into your own clinical practice. So please join in on the 29th. And for all those who are interested in following up functional neurosurgery, please log on to the ISSFN website. Thank you.
Yes, Bhaskar, please go ahead.
After you.
Yeah, so no, I just want to thank all the speakers, and I am sorry that your presentation couldn't come through, Bhaskar. But I think we have had a very good webinar on epilepsy surgery. I think we have sensitized all the participants to the capabilities of this modality, and let's hope that some of them will take up this area of specialization. So with that, I hand over to Bhaskar Rao.
Thank you very much for moderating this webinar. I could not present, and I'm really sorry about that. But in spite of failure of my presentation, I'm really delighted to have almost 350 participants in this webinar. Actually, the ISSFN membership is about 150, and 200 more people joined this webinar, and I'm sure some of them must be potential members. So I request all of them to apply for the ISSFN membership, contribute, get something good out of the society, as well as contribute to the ISSFN growth. The content of this webinar will be available at the ISSFN website shortly. And regarding the